I know we got to get out of here before 4. What was that? Was that like?
Cause you guys have things to do,
I
right?
have to go back to work. These guys have to drive all the way back to Cheyenne tonight.
Well, that's fine because I have a couple more budget meetings to go,
I
so
figured
I'll
that,
go ahead.
and I know you said you have way more important things to do. But
No.
thank you for taking time to meet with us. We started a program we're calling Rural
Communities Project's a working title.
Rural Communities Project.
Cool.
It started just with an idea of how can we help rural communities. We're working with the Harvard Growth Lab at the Kennedy School, Business School, to try to really take kind of a holistic approach and understand what the community's challenges are, learn from the folks in the community, and then these two are our data analysts from the Cheyenne office that can help bring that together.
Great.
So I'll let them introduce themselves, but Newcastle is one of 7 communities that we decided to put in this program, pilot communities.
Yeah.
Great, great.
Yes, I'm Connor, one of these analysts that she speaks
Speaks
of.
of.
Yeah. We both started in January. Both moved to Wyoming. Moved here from Chicago.
Wow.
So this is great because one, it's just nice to go around the state and learn from people, talk to people, and see what it's all about.
Right.
It's also good because we're doing our analysis, but it's really important to pair that up with people on the ground, if you will.
Right,
Doing
right.
the work, and so we're learning a ton through this, and we're looking forward to pairing up the analysis with talking to the mayor and all you to figure out what a plan could look like for whatever the people want their community to be. So.
Okay, very good.
So my name is Vinicius. So we are in this role that's economic policy and research advisor. So there's a lot of bringing data and evidence to what we do, but with a focus on using the data to inform public policy to generate jobs and growth. And I think I'm glad to be here and learn from you
Great.
your experience in the hospital.
Great, thank you. Okay.
I'm part of the regional director, but I'm based out of Cheyenne.
Okay, very good.
Kathy and I met when we were judging the
Christmas.
Christmas
Oh,
lighting.
nice.
Perfect.
We were judges on
Nice.
You're,
So-
Yeah.
you're judgy, yeah.
You guys are the,
Oh, sorry.
I was just gonna ask her to give background.
Oh, yeah.
How long you've been here? Tell us about you. How did you?
Oh, I've been here, it'll be a year this month, the 24th. I actually started out as an interim CEO, and a lot of that just came about because I was here and I wasn't working. I had been taking care of some family members, and I saw that the hospital was in need of some help and support, and I had the skill set for that because I've been doing that CEO work. And so I called up the board chair and said, you know, I see that you guys need some help. I could probably help you in the interim. And so then in October or September, I can't remember which one it is right now, but I became permanent. So I worked on things. So
Congratulations.
thank you. And really, the facility had been through 2 CEOs that were pretty in and out, is the way I'll call it. And a lot of,
That's very diplomatic of you.
yes, in and out, and a lot of business challenges, relatively speaking, because of that. You know, when you have a small facility, you don't have huge margins and stuff anyway, and so the bookkeeping, the bookkeeping was really pretty generous, to say subpar. And so then basically we've been spending a whole year still cleaning up all of that, the bookkeeping piece of it, trying to make sure that we're moving forward to try to build growth. We had only locum, we had doctors retire, and then we had only some locums for a while. We're now gonna have 2 permanent MDs, and we have a permanent nurse practitioner. I wanna hire at least 1 more provider, so that I'm gonna try 4 and see if I can get 4 to get the business that we need to stabilize it. There's a real big focus gap, in my opinion, that is around women's health and pediatrics, and so I'm trying to find somebody with a focus in that area, and probably female, not to sound prejudiced, but because we have people that wanna see only a female. So, that's our next charter. And I've actually interviewed a couple of people, but I'm still working on that.
So tell us about your facility, your staff, how many staff do you have? Is it hard
Well,
to fill
I
those
haven't checked on that
positions?
recently, but what I remembered not that long ago was right around 211 employees.
Wow.
But our FTE count is more like 160. So we have quite a few PRN people or part-time people. I'd have to recheck it again because
That's
we've been
fine,
going
just
back
to
and
give us
forth.
an idea. Cause you're
Um,
definitely one of the largest employers in the
Yeah.
town.
And our nursing home has gone from 36 patients, now we're at 52, I think it is right now.
Went up
So
some
we've
more.
really had a growth moment, which has put us into a real crunch for getting certified nursing assistants. So we've been using travelers, which is very expensive to get us started, and then we have a hybrid program, which has been very successful, more successful than I thought it would be, which is the CNAs are doing a hybrid program where they're doing didactics online from home, getting their testing and stuff done. Then when they're done with that, they just have to come here for their on-site curriculum piece and doing their hours. And then once they're done with that, they can either work full-time here or there's a couple of people that work other places too. So we used to have barely enough people to make a class. And now we've got something like 11 people that are going through the CNA class just
Nice.
because it's being hybrid. So I
And
think
you
that's.
guys offer that?
Yep, yeah.
Is that pulling local kids or young people, like
Yeah.
out of high school or?
Yeah, it's out of high school, young
Yeah.
people, so it's definitely drawn people in a lot better, so.
Good.
The fact that they can use the technology and not have to be, what it does is it allows them to work where they're at while they're trying to get trained to be able to do something else and to step into medical field, so I think it's a good
Good.
combination. And then, so we have the nursing home, we have a hospital that's got 12 beds for acute care. We have swing beds as well, that's part of our patients that we see, they are all in that kind of the acute area. Swing bed patients are those that aren't in the acute side but need rehab, some sort of rehab, to be able to get back on their feet and ready to go home, to be discharged. We provide lab radiology. Our radiology department has a portable MRI machine 2 times a month, and then we are just now gonna get a new CT scanner this fall. And that will be great because it's gonna add some modalities for us, like we can do a better job of predicting people's cardiac risks so that we can actually try to prevent heart attacks from occurring prior to them knowing, and then we can do some special echocardiogram pieces too with that. So we've added actually additional services, another couple of days for the echocardiograms that I was talking about. We have specialty clinics that we're starting to grow. Those take a little while to get credentialed and put on site, but those are things like, got a couple of orthopedic doctors, we've got cardiologists, we have behavioral health, we've got a couple of people coming for behavioral health, and we have a neurologist we're working with right now, and an ear, nose, and throat doctor, so that they can come. The challenge there is that a lot of them wanna be able to collect their professional fees themselves, and so we rent space to them, so we don't really make money per se off of it, so to speak. It's more about making sure you have the specialties there. Yeah, now my CFO would love it if I could get them to let us do the pro fees and we pay them at per diem rate, but it's not working out very much like that, so they wanna do their own thing. And
Do you have an ER?
we have an ER, it's a level 4. And we have 2 clinics. We have a clinic here across the street, and then we have one in Upton. We have physical therapy, PT, OT, and speech is by contract. And we have an outpatient infusion area.
Nice.
Yeah, so that's kind of our services. Oh, home health.
Therapy, physical therapy.
Yeah, I said that one just
Oh.
now, sorry.
I didn't
And
know.
home health, and in-home services, which is actually a grant program that we do for people that are low income that need help in the home that don't qualify for in-home care through the skilled programs that the Medicare have, or Medicaid.
We have a pretty large need for that in our community too, don't we?
Mhm.
The city provides a subsidy,
Right,
for that service.
Yeah.
I think it's great.
yeah, it's a
Like
great service.
What pediatric?
Yeah, I think it helps
Pediatrics,
supplement their
we
budgets
are in a
to
gap
get
on
help
right
to
now.
people.
I did hear there's a pediatric doctor going to the little clinic that, no, don't throw up their names, I can't do it. Hometown Medical Clinic, isn't that what it's called, hometown?
Hometown,
Yeah, they have a clinic and they have a pediatrician that comes there part of the time.
And that's another clinic that's within the town.
Yeah, it's a
Yeah,
separate clinic, it's a private clinic with two, FNPs that work there.
We've been talking about housing today a little bit.
Oh, yeah, that's,
So, where do traveling nurses stay? I don't know how that works entirely, and then have you had staff that you wanted to hire but didn't work out because of housing, or do a lot of them opt to live not in town here, that kind of thing?
what it does is cost us a lot of money, because what happens is we try to find what housing we can for rent, and
Yeah.
people charge us premium prices, most of them anyway, because we're a hospital, I don't know why else, but, we've had to rent, I think 4 rentals, plus we have a house that we own, so that we ourselves are renting them to be able to have travelers that come in and work here. The other thing is that those things that we have for rentals aren't necessarily, they're outdated type of homes.
Yeah.
That's what I would call it.
It's a TLC.
I'm being truthful, but I don't know, Walter, if we wanna put that in there, but they are outdated, they're outdated.
I need to take some lessons from you, Kathy, on being diplomatic. You're really good at it.
She's a
Well,
good diplomat.
You know, it's really quite challenging. In fact, I would have lost some candidates had I not found housing for them for the first 6 months. And then even then, I've had people have to extend because they're trying to find a house to be able to afford. Cause it seems like the houses are either someplace a little outside of town and real expensive, or they're just not, dilapidated, yeah, that's right. They're just not attractive to, like if you wanna get young workers working here and stuff.
Yeah.
That's gonna be a real challenge. Housing is, I think it's a big deal here. That's what I think. I don't know what you think, Mayor, but I think so.
Downtown for
I
apartments
think
just have
the
those.
consensus is, that this is across the board, everybody that we talk to,
Mhm.
thinks that housing is an issue.
Mhm.
For apartments, you said your sister lived on the main street there. Is there just a few apartments there?
Yeah, there's just a few apartments on the
Yeah.
upper level of that, like downtown building.
Okay.
And then there's a few apartments above Stewart, but, kinda going back to what Kathy said,
Outdated.
we're a little bit outdated.
A little bit.
Well, I mean, if you like the 60s and 70s, you're in pretty good shape.
Does the hospital own any land that you could develop into housing at some point, or?
No,
on your
not
own
really,
units?
right now, they don't, I mean, surely it'll be interesting to see what we try to do as a community, but we don't really have any land for development, because I know I had that at another facility I was at, and we were looking at whether or not we could provide senior housing and some of the others, with some of the loans you can get when you start using it for economic reasons and stuff, but, it's a real climb to try, because you gotta try to find somebody to help pay for those, and so a lot of times the ones that you can have help pay for that is to put people into senior living or low income type of apartments. And then if you could have a campus that was like that, it would be lovely to have some kind of concierge service for patients that are older, that they could have their family they could have their doctor visit them, because they're literally right around the same campus area, but we just don't have that yet. And then the other thing I think that's especially important to think about counties like ours is that mean, we have some patients for the home health that are an hour and a half away, for them just to drive there one way. And then, and back, so from an economic standpoint, that doesn't play super well for being able to provide those services like we want to be able to do that. And so, I think that's a barrier as well, so.
So Kathy, back to the housing,
Mm-hmm,
say, you know, there was some mechanism for the city to leverage some funding
mm-hmm,
to put in some apartments or put in some kind of housing.
mm-hmm.
Like, what, what's the shortfall? Like, what would be a good number for you to house the people that you need to house?
Geez, I mean, I actually think that, given what I know about what we're at, I'll bet you we would use at least a dozen places ourselves, 12, you know, yeah, mm-hmm.
So,
I mean, I have some people, I won't even tell you about the place I have some people staying at because I'm embarrassed by it, but, you know, it is what it is because it's the space I have available, so.
This facility doesn't seem very old.
This building,
Yeah.
it was, when was it built, Walter, in 2008?
Somewhere in that area. I wasn't here when it was built,
Mm-hmm.
and so I don't know
It's
for sure, but
definitely
that
not
sounds
Halliburton
about
money.
right.
It's got ceilings that are higher and we don't have any green cupboards or anything like that, you know, so. And it's a nice building, and it's been kept up pretty nice. There's some infrastructure that we still need to update now, like you always end up having additional HVAC needs and things like that, but,
Always.
yeah.
they built an addition on the hospital probably 10 years ago.
Yeah.
I was still working for the city and, they did an expansion over it.
Right, the specialty clinic is part of that, I think, was part of that, so.
And then I was working for Newcastle Ambulance Service in 2009, and then I guess they're on.
You had a lot of jobs.
No, and that would be the other one. I know the state's trying to wrestle with this one, I don't know how hard though, but EMS is an issue. You guys probably know that, so, one of the challenges that always with EMS is, number one, you have to get people trained up to be able to do that at a certain level. And then there is great distances between places, and if you don't, our problem isn't as much the 911s, although that can still be quite a while waiting on a 911. It's the transfers between this facility to tertiary centers. So, you know, we're not going to do an interventional cardiac piece or something. And so, we have the transfer problems from that standpoint. So.
And this county currently is going through the possibility of whether we're actually gonna be starting an EMS district or keeping it with Monument Health.
Right.
Monument Health?
No,
Campbell County.
Campbell County.
And, so that, and that's just come up in the last 3-4 months, I think.
Mm-hmm.
And so it's still an ongoing process, and you're looking at maybe 2 or 3 years out if the county actually votes to start an EMS district.
But and here's the risk factor that I find very scary, which is like we've had to have people go by private vehicle that have an active, serious problem going on with them because we couldn't wait for the 4 or 5 hours it was gonna take for them to get seen. And so that's a liability on our side for sure, but it's also, it's not a good solution. I mean, it's just not a good
And
solution.
it's a bigger issue then,
Mhm.
because you're contracted with Campbell County Health, so
Mhm.
then they pull the ambulances from Wright over here.
That has happened.
So it's even a bigger problem than just this
Yeah.
area.
That actually
And then when you
negatively
need to transfer somebody, then that ambulance from Wright
has
goes
to
in Rapid
backfill.
City and then has to come back. So I mean, we're talking 3 hours.
Or sometimes they go to Casper,
Or they go
sometimes
to
go to
Casper or
Denver.
Cheyenne or Denver.
And so it can be, well, we have talked to air ambulance to see if they would do some of our transfers, and I'm gonna see how that works, but they're talking about being able to make that as comparable as what it costs for mileage on on
Oh, really?
on a
Wow.
ambulance, but, cause our people that have to go by ambulance, they don't get a cheap bill either, because that mileage clicks up pretty fast,
There's no
so.
place for a helicopter.
Yeah.
Yep.
Mhm.
There's a spot back there, that was an issue that came up too, was we were kind of alarmed by the number of life flight, that people heard coming into town.
Mhm.
So whether it was, they were actually transferring somebody, we were wondering about the ambulance's capacity to transport or transfer. I used to have to run those transfers too through the hills.
Well, and
It's
then
kind of lost.
it would be wonderful if there was some way that Campbell County, but I don't think they can. I used to have a partnership with, but this is in the Colorado area, we had a partnership with an ambulance service that put their helicopter on our site and had their people there, and they would rotate in and out over a day or so, you know, and depends whatever their regulations are for their sleep and flight times and stuff. And that worked out pretty good, but you have to then have space that they rent from you, that you build basically, and do that sort of kind of piece, and I don't know where I would put somebody right now, so.
Can you give us just a real high level of how, so I know that there was a big vote, levy vote last fall. How is the hospital funded? Is it a district or a county hospital?
It's a district hospital, and it's funded with the mill levy, which we just got passed for an additional 3, but now we have that 25% tax, property tax reduction. So what we were even trying to achieve, we've gotten a reduction on, which I'm concerned about, for sure. People that voted for it probably aren't, but I am, so, you know, the 25%.
I think,
Do you know what that means for your budget?
I think it took us down to, I think we were gonna get 1.2, I'm trying to remember, and I think it took us down to 800 and something.
400,000?
Yeah, eight something.
Besides that part of it, was that the first time it was voted on here?
No, it's been voted, there's an automatic 3 mil levy that's given to districts, and then every 4 years you can have an additional, 3 mil levy.
Okay.
But it has to be voted
So
on
that
by
was
the
already,
public
like,
every 4
Mhm.
years.
How was the voter response to that?
It was in favor, I wasn't sure, cause we kind of went through a reputation problem with CEO changes and things like that. And, but we did get it, I think the community knew they needed a hospital, so, and so they did vote for it, thinking it was, yeah.
it's been pretty scary a couple of times, even with the EMS concerns that people were gonna vote in favor. Cause there was, you know, I had to get pressure too as the mayor, like, or on the council at that time, it was like, well, we understand that we live in rural America, and that we're not necessarily gonna get an ambulance, you know, and so they didn't wanna be, yeah, but so, it was a rough one.
So that you're the one that needs an ambulance.
And this is one of the largest employers too, I mean, that would be devastating.
Yeah, it would be, and it's, well, I don't know, there was some opportunity to have more cash available than we do now, you know, in our piece, and so, we don't have that same amount of cash, and so really, we try to work with a month to month right now. We have 5 million in reserves, but that 5 million, part of it's ear tagged because we have loans and stuff like that. And so we're really trying to work, well, for whatever reason, somehow this facility got to working sort of like a cash basis instead of the way hospitals run completely. So we really are trying to work month to month with our revenue to make sure that we can cover our expenses. And so the budget is a really big deal because things don't go down in price, they go up. That is not, I've not been in one hospital, one clinic or anything where the prices go down for things. And so we've seen groceries go up, we've seen all these things go up, medications, and now with the tariffs, I'm not sure where we're gonna go with that, except we've already started to see increase in pharmaceutical pricing. I'm not blaming the tariffs, I'm just saying it's a fact of nature right now. And so, part of it is that how do we grow? Because if we don't grow, we die. That's my opinion. That would not necessarily be everybody's. But if we grow, then we can maybe cover some of these other extra costs. If we don't grow, then we have to figure out how to reduce our expenses, which could mean services would be limited in order to get to the number that we need to in order for people to feel comfortable. And that's like my last thing I wanna be able to do, but, I don't know, cause I'm in the middle of it right now, so this is a bad week to ask me that question. Cause right now I feel like I have no money, but, it's like, it's a reality, you know, every time we turn around.
Is it an elected board? that
It's an
you
elected
answer
board.
to?
Mhm.
As a county health provider, can you, you establish a foundation?
We do have a foundation. They have given us some money for some things. There was a little bit of a bump for a while because everybody was pretty mad at the hospital, but we are now doing good as a partnership, and they've actually funded a few things for us lately. We've also been getting some fundraising done for our CT. We had a $500,000 donation, and then we've had some at 70,000 so far, and then we got another 45, I think, that's promised to us, and so we're trying to get 300,000 more put together. So, you know, we're living on the edge. We like to try and do what we need to get where we go. It's like living on the edge, but I do think one of the challenges is that we can only grow so much. We can't grow ridiculously because we're not big enough, but we get charged the same as any other hospital for a lot of the things that we have. We did get a discount for Microsoft because we're a nonprofit, but there's a lot of places that don't discount us over our nonprofit piece. And so software systems and things that we have to be able to run according to regulations and stuff. So that's gonna be really tough over time for facilities like ours, that how do you keep up with what's expected as a standard of care, and at the same time you just don't get deeper coffers necessarily, but you do have to have some growth, I think, in order to, well, for one, to be able to provide access to care that you want to give to people.
Here's when you talk growth, you talk about growth in the number of customers, revenue, a little bit of both, and I'm curious to know how has been the trend in recent years.
Well, I think what we had for a while is we had a little bit of a downturn. Our radiology department's come up pretty good now. It's some of the things we're doing with that. I think we have some more opportunity in a couple of areas, but our nursing homes gotten much busier. We only have 5 beds left, I think. So, and so that's helping us. But we also had to add staff for having additional people. So there's an offset to that a little bit. But do I think that we've maximized where we could be? Not necessarily, no. I think that we could grow some more visits, like for the physicians, but we had to have physicians that were consistent to be able to get that happen. And then physical therapy and swing bed and stuff, that's really dependent on us communicating well with our partners and the other facilities that want to not have that patient in their acute care bed, but still needs additional care. So it's getting people back. We have been getting people for swing bed, though they're as far away as Gillette and Lusk and I'm trying to think of, I think we actually got one person from Casper, so we have been getting people in it further out. But that's because they don't have the services for the persons right now, so.
What's your just estimated overall budget annually?
Well, I'm working on that right now, but I think that the last budget that they had annualized was 28 million or so. I think that we're trying to look at, see if we can get a little higher than that. And, but our expenses last year were like 28 million or so. So there's gonna be a loss in this year. There was a lot of consultants that we had in the building for trying to figure out why the facility was so broken and trying to get it fixed. And so we won't have some of those pieces in place, but that's why I say we have to come up with some growth, because the only other thing is to say, okay, this business is great for the community, but it doesn't bring in the dollars to cover the cost. And it wouldn't be and I hate saying this in front of the mayor too, but it wouldn't be strange for us to have some of those things not part of our business, just because other hospitals don't tend to do that. They just don't tend to do it because they lose money overall in their budget. And so I don't really wanna do that. I wanna be able to provide all the things that the community wants. I just don't know where the dollars are gonna land yet. So I'm sure you're dealing with the same problems.
It's the same
Mm-hmm.
trouble with every board. I mean,
Mm-hmm.
rising costs, trying to determine what's necessary for the community and what you can cut.
Mm-hmm.
And I'm a yes man, I want everybody to be happy.
Mhm.
But it makes for hard decisions.
It does, it makes for hard decisions, and so I'm just saying that because do I have to make hard decisions? I might have to. It depends on where my board really wants to land in cost containments. So,
Is your board pretty active? Like helpful, active?
yeah, they're very active. We have long board meetings. So I'm not kidding them. I was like.
No, you're not kidding.
A 6-hour board meeting, so.
Oh,
But, yeah, they're active, they're definitely active, and, they come from different backgrounds, and I think boards are boards. We're doing a lot of training and, a lot of that too, because they don't necessarily walk in, they might know about looking at a balance sheet, or they might know how to look at a P&L sheet, but they don't necessarily know how to look at it from a hospital, nursing home perspective, and all of those kinds of pieces, so.
Well, I think you have another issue that goes there, because some of these board members, some have had their own businesses and things like that, and so they've made their own decisions, and then they come here and they've got that's one individual that has a vision, and there's, how many board members here? 6?
7.
So there's 6 others that may have a completely different vision, and some of those discussions and arguments, and I will go ahead and say it because sometimes it is an argument, that gets very interesting on how things, especially when you're talking about the balance sheet, that can get very interesting to see how that process goes.
We have some popcorn and start coming down and watch the meeting.
Yeah, you should. Somebody needs to do something. I'm not
Oh
sure.
my gosh, next time I'm gonna have
I tried
a
to do a
big,
consent agenda, but that didn't work for me, so.
Are those, how many board members selected?
They're elected,
Okay.
they're elected by the community.
So it's on the ballot?
Mhm. The only time that they're not elected is, and that they're appointed is if it's at mid-year, somebody leaves, or mid their term, then they will select someone.
So you don't have any answer?
Mm-mm.
Is there a lot of overlap between school board, hospital board, all the other boards, board around here? Is it pretty unique groups of people that are involved on the board?
Yeah, I don't think we have any overlap right now.
No, there's
but
none.
Sometimes, like we were talking about earlier, I mean, we have people that have to get on other boards because there's not enough participation in the community.
Yeah, and I don't know if I should keep my mouth shut on that one, but I do